Order. Welcome to this evidence hearing of the Health and Social Care Select Committee on Food and Weight Management. This is our 6th session of this inquiry, and today we are looking specifically at GLP-1 jabs, or weight loss jabs as they're more commonly known. May we have our panel introduce themselves and what they do? Can we start with Dr. Kieran?
Thank you. I'm GP by background, Dr. Kieran Seyan, and I've worked in digital healthcare now for 10 years, representing Pharmaceutical.
Good morning, I'm Claire. I'm the Superintendent Pharmacist for Boots. So my remit is to head the professional agenda for Boots pharmacies across the UK. And I've been a pharmacist for 30 years and an independent prescriber as well.
Good morning. Thank you very much for having us here today. My name is Dr. Simon Doyle. I'm also a GP. I lead public policy at Juniper. Today I'm representing a new member coalition called the Coalition of Responsible Digital Health, or CORD for short, made up of Juniper, Newman, SheMed, eMed, Voy and Simple Online Pharmacy. We are all digital-only providers, and we've come together really to advocate for proportionate and effective regulation that enables safe access to digital care.
Thank you very much. Andrew George, please.
Thank you very much. Dr. Kieran and Claire, could you give us an indication as to the sense of the scale of the demand for GLP-1s in the private sector and how that compares with prescribing through the NHS?
We know that demand has increased significantly over the last couple of years. Patient interest in the condition and more availability of information to the patient around this particular set of treatments. Also being very effective as well, so patients seeking this type of medication. And so demand has increased rapidly. The NHS access is limited at the moment, so patients are seeking this more in sectors outside of the NHS.
Can I just interrupt you there?
Please.
I mean, what proportion of those that are obtaining your services do you think would otherwise be eligible for NHS services? Should it be less restrictive?
Going by the licence of the medication, then all the patients who are requesting medication from our service would be eligible for NHS service, going by the licence, not the NHS criteria.
Okay, and Claire, through your services?
So we know that there's around 1.6 million patients accessing GLP-1s across the UK currently, on average. And most of them are accessing them through the private sector because of accessibility and because the wraparound care and what we can provide through the private sector is what they're looking for, with limited access to NHS services. We support thousands of patients every week through the Boots Online Doctor online service, and we've just introduced a face-to-face version of that service delivered through our Boots pharmacies as well, and we're seeing demand from different parts of the population to access face-to-face care too. So the demand is definitely increasing.
Right.
If I may jump in and just
yes.
add to that, I think it's really a complex question because the NHS eligibility does vary from area to area, and we've seen it vary over time as well. So we saw the initial NICE guidance, and then we've seen the funding variation, then we've seen priority groups, and then within different ICBs we're seeing criteria become more stringent as well, which is part of the problem that's caused the postcode lottery. If we're talking about our member organisations, if we take the original NICE guidance, what was intended to be implemented over the 3 years, up to around 20% of our patients actually meet that criteria. So having a BMI more than 35 and an associated condition, or a BMI over 40. So I think that really shows that the digital providers or the private sector providers are working alongside the NHS to actually manage the obesity crisis.
Yeah, and so you mentioned earlier the creation of the new organisation, the Coalition of Responsible Digital Health, and I mean there's a strong emphasis on the word responsible there,
Deliberately so,
and deliberately so. So does that mean that obviously you're by definition those who are not members of your organisation are irresponsible?
Absolutely not. Absolutely not. Like I say, we are a relatively new coalition, and one of the things we're trying to do is make it clear that not all physical premises are the same, and equally not all digital premises are the same either. I do believe there is a role for digital providers to be able to provide responsible and safe care. At the moment, we have set up, because we are digital only, and we're working towards 3 main pillars in our code of conduct, and that's around safe prescribing, ongoing care. So we're not just a one-off transaction. We are able to provide ongoing medical support. So that means an element of side effect support, dose titration, and education. So we're trying to change behavior along the patient's weight loss experience as well. And the final pillar around responsible communication. We live in a world where there is, unfortunately, lots of misinformation out there, and we're really trying to do this correctly, and we're keen to work with regulators, with the ASA, with GPhC to make sure that we're doing it correctly.
Okay, we'll come on to regulation in a moment, but just in terms of your modus operandi, I mean, have you considered applications for membership and rejected them so far?
Not at this stage, because we are very new. We've recently launched our website, which lists our code of conduct. If other members meet those criteria and are willing to work towards that code, then absolutely we would consider increasing our membership in the future.
And do you have the resources to act as the kind of gatekeeper to your own standards?
We're not talking about gatekeeping anything here. We're talking about trying to build an environment of responsible health. If more members want to work to those principles that we have set, then I would absolutely welcome that, because that's only going to mean increased safety for our patients.
It's like a kite mark that they can put against their name, is that effectively?
It's less so about branding, it's more so about how we're actually working together.
Right, and so just coming back to the differentiation, I mean, you're a practicing GP, and therefore you will see patients coming to see you through your surgery who will be eligible for NHS treatment, and are able or unable to obtain that treatment. I mean, what barriers stand in their way as to why they might seek a private digital provider rather than go through the NHS route?
So I think there's multi-factors there. So I think, again, just to reiterate the point that where I work may be very different to where somebody down the road works. So that's one.
And where do you work?
So at the moment, my main job is with Juniper, but I still work in central London as well.
Central London, okay.
Yeah. So I think one of the main barriers is around the variability in criteria. The other thing that I'm seeing in practice, and that lots of my colleagues are seeing in practice, is patients are very keen for treatment. They've tried lots of things over years and years without much success. We're now getting to the point where, unfortunately, because of the way the funding has been allocated, patients are being told you're not unwell enough yet. And we're talking about this as a piece of the prevention puzzle. However, it doesn't really make sense to me that we're waiting for patients to become more sick before we can start that prevention piece.
Right, and I mean, in terms of your experience, I mean, are you still a practicing?
Not within the
GP,
NHS.
not within. But you have recent experience.
Yes.
I mean, what changes do you think, for those on the front line, what changes do you think would be necessary in order to, I feel like, facilitate better the access of patients through the NHS? I mean, obviously you have a private interest in driving patients to your private practice, but on the other hand, you must recognise that obviously it would be better if the NHS were better able and patients didn't need to fall more ill in order to access NHS services.
Yes, I would agree with my colleague. This is very much multifactorial, and it does depend on the area, it does depend on the patient themselves. The challenge that we face within the NHS is the accessibility. And so if accessibility, the criteria was to change as per the licence, then more patients would be able to access this medication as well. Mm-hmm. And also the type of consultation that's available. It's not possible for general practice to cope with the volume of patient demand that there is. And so we need wider availability of access to care. That could be through digital, that could be through pharmacy, combination of the both, along with general practice as well. So unless there is more open avenues, it's going to be very difficult to serve all of those patients.
Right. Can I just be clear on the point of you're saying that you obviously provide a licensed service that actually meets your own, and will come on to the regulatory environment in which you operate, but all of those patients that you're supporting through private digital supply, would otherwise be eligible for NHS services, and that's what you're saying. And so I mean, it seems to me that you're taking the vast majority of patients that the NHS is dealing with a very small proportion overall.
Yes.
And what I mean, approximately what kind of proportions would you say?
The estimations which I've seen is about 80%.
80% of the market. Is that? Yeah. I mean, Claire, I've left you out of the conversation on these issues. I mean, you're obviously a very large supplier of these services. I mean, is this pattern of activity one that has significantly changed in recent times, and what proportion of your sales do the GLP-1s represent?
So our online services for weight management we've seen significant demand over the past couple of years since the availability of new GLP-1s on the market. We've responded to that demand and developed clinical services, working collectively as a digital providers to make sure that those services are delivered with the right wraparound care and the right support for patients. It is an important part of our healthcare strategy. It feeds into the ambition that the NHS has as part of the NHS 10-year plan to focus on prevention, and weight management is a core and a key service that we need to look at to support people to prevent longer term conditions. So it's a service that we can provide safely and professionally online, and in Boots we can provide that face to face as well, which really helps us to meet the ambition of giving people access to services that help them to stay well and to prevent further long-term conditions. So it's a significant focus for us currently as a business.
Just finally, I'll ask Dr. Seyan, on the coalition, the role of the coalition. You felt recently compelled to establish it, presumably because you're well aware of poor practice and irresponsible practice elsewhere. I mean, are you prepared to identify where that irresponsible practice is taking place? Are these UK-based organisations, or are they suppliers from overseas?
I think that's probably a role for the regulator to identify or call out specific companies rather than a role for myself. However, I think a core principle of what we're trying to do is to show that broad brushstrokes aren't always correct, and there's lots of attention, rightly so, in the media around bad actors in this space, whether that be through regulated providers or unregulated providers through social media, etc. And what we're trying to do is to show that that's not the case for all digital providers.
And I mean, is there a problem of overseas supply? Is that one of the areas of concern that you're...
Clarify, do you mean patients in the UK obtaining from overseas?
Yes, that's right. Yeah.
I think, well, my point of view is that medications in this country should be obtained from a regulated provider in this country so that patients have reliable access to ongoing support, which again is that wraparound part that all of our member organisations provide.
Okay, thank you very much.
Greg Stafford.
Thank you very much. So first, a relatively general question. When it comes to your GLP-1 services, what could the NHS learn from your experience? Very briefly, Dr. Seyan.
I think the NHS would perhaps gain some knowledge around the scalability and efficiency that digital services can provide, the access to structured longitudinal data, identifying risk at early stages, and the ability to create an environment where patients can access care early, and it fits in with very much the digital age that we live in as well.
Yes, so I agree. I think what we have learnt through our provision, through online services, and through our experience of providing preventative type services through community pharmacy is that we know that what's important to patients is access. Is important to be able to access services where people live, delivered by people who can really relate to them and to build a relationship with them. We have, as I say, supported thousands of patients every week through our online services, and we're seeing the support delivered through our bricks and mortar pharmacies also playing a really important role. So I think it's mostly about new pathways of care that allow patients to access these important treatments in a way that really works for them, and ensuring that wraparound care is available for everybody regardless of how they want to access these services.
Thank you. Dr. Doyle.
Yeah, I'd emphasise Claire's point around new pathways and build on that, to be honest. I think if we look at what the original modelling was for how this rollout could work in the NHS, we were looking at the equivalent of 21 GP appointments across a year. I think what the NHS could learn from digital providers is that actually we're in a position to rethink what a model of care looks like. We're able to provide patients more flexibility and more choice. Instead of having one blocked 15-minute appointment, patients may prefer to interact with their point of care throughout the week through asynchronous messaging, which provides a lot more flexibility. And the reality of that is, if we look from January this year, our member patients have treated more than 250,000 patients already, or have more than 250,000 active weight loss patients. When we compare that with the NHS ambitions to treat 220,000 over 3 years, I think it really shows what can be achieved by changing the model of delivery.
Thank you. That's really helpful. So moving on, we've heard in our, we've heard in our evidence, and indeed you've re-emphasised it now, about the potential for digital services to improve access to GLP-1s. So what are the practical changes that need to come about to unlock that potential? Maybe go the other way, Dr. Doyle, to start.
Yeah, I think one of the key things is that trust part between the public sector and the private sector. I think we've spent years building these platforms, learning from the process as well, and creating a large evidence base. So all of our member organisations are really proud of their evidence and show that they work. For example, Juniper has a paper showing that patients are twice as likely to achieve clinical weight loss, clinically significant weight loss compared to medications on their own. Voy has similar results with 21% weight loss versus 17% weight loss at 12 months. So I think we've shown that we are credible. I think the thing that can really unlock that is also interoperability. So a simple example of that is private companies are blocked out by default from access to summary care record from the NHS. Now, I would point out that doesn't inherently make private providers dangerous. That's very similar to how a patient may go to a private GP practice and that GP would not have access to the summary care record either, or even NHS services such as sexual health don't have immediate communications with general practitioners. But I think there is something around the interoperability that we would love to see change.
Thank you, really helpful. Ms. Nevinson.
So I think I agree on the interoperability point. I think from a community pharmacy perspective, I think there's a real opportunity for the government, for the NHS, to really look at the role of community pharmacy in supporting people to access this type of service. Delivery through the community pharmacy setting, with the capability of the healthcare professionals that work in our community pharmacies, which is growing over time as we see independent prescribing becoming more mainstream. This type of holistic preventative service is perfectly placed to be delivered through the community pharmacy network.
And just so I'm clear, are you suggesting that the sort of first presentation is the community pharmacy and then they're somehow managed through a digital means, or are you talking solely through
I think there's
pharmacy?
Definitely opportunity to do both. I think there's a hybrid model that we should look at, and we have evidence to show that people have really successful weight loss journeys using digital means. And of course, the way people are accessing information and advice and support is typically through digital channels now. So I think there's a role for community pharmacy to play a bigger part here. But I think listening to what patients are choosing to do and how they're choosing to access healthcare is really important too. So I think there's an opportunity to look at a hybrid approach.
Thank you. Yeah.
Thank you. I will only support really what my colleagues have said. The interoperability is really important, a single patient record, which we're looking forward to. Again, I would agree with Claire with regards to the support from pharmacy. If we think of it from a patient perspective, there needs to be access to healthcare from different means, and that could be in community, that could be via digital, but actually needs to be a hybrid model.
Thank you. So you've obviously expressed that you're doing about 80% of the market already, but do you feel you have the capacity to scale up to meet the demand that potentially in the ways that if we were to move to a model that you're describing?
The sector is not new. As I mentioned, I've been working in this for about 10 years now, and really this type of digital model has been around for at least 20 years within the UK. So this is an established way of delivering healthcare. and we are very, very aware of the risks that are associated with it, how to run an operation. And so I think, yes, we are able to scale, and there'll be several other providers that will be able to do the same, but Pharmacy 2 is absolutely ready for that.
Is that the same for you would agree with that? Robin?
Yeah, I'd agree
I
with
would
that.
agree with that, yeah.
Okay, thank you very much. So have you done any modelling to understand how many more NHS patients digital providers could support? Have you, or are you suggesting, Dr. Seyan, that you sort of have an almost infinite capacity to deal with as many people as possible, given the model you're describing?
I would say, I wouldn't say an infinite model, because there is still a limited amount of clinicians, but what digital can do is allow for scale and efficiency, and different to the
What I'm trying to do
model.
is get an idea of sort of practical idea of numbers. So have any of you done any modelling to say, well, we could treat X number more patients if we did this, just so we can the committee can get some idea of how the numbers we're talking about here?
I think this is something we could provide afterwards, because some of my colleagues would have done that work, but I don't have those.
Please write to us afterwards, that's fine.
Very helpful. Okay, slightly on a tangent, but in your opinion, does the Obesity Pathway Innovation Programme, is it ambitious enough to meet the current demand for GLP-1s?
Can I jump in
Yes, of course.
first? So I think the first thing I would say is the programme is a great start. It shows thinking differently, which I think is what we would all welcome. I think involving different government departments is really helpful. So Department of Science, Innovation, Technology, rather than just Health and Social Care. And I would welcome more of that cross-department thinking and joined up thinking, and maybe even bringing in Department of Work and Pensions as well. Tony Blair Institute have done some brilliant modelling with frontier economics around how different government departments can all benefit from this. And if you haven't seen that, we're more than happy to provide that report for you. In terms of the limitations of the OPIP programme, as it's known, is my concern is around, we already have a postcode lottery. There's going to be some brilliant pockets of innovation for those who've been successful in the OPIP programme. However, I know lots of ICBs have put a lot of work into their bids and now unfortunately have been unsuccessful. So I think it's a great start. Do I think it's gone far enough to level the playing field? I'm not convinced yet, but I'm really excited to see what comes out of it.
Thank you. Anyone got anything to add to that? No, well, I'm going to jump a question that I have because you've touched on it now, Dr. Doyle. So we in our evidence gathering, we've heard some very strong calls for the weight management services and treatments like GPL1s to be nationally commissioned. Is that something you support, and what would it mean for your business if that did happen? Dr. Seyan.
Yes, Pharmacy 2 would absolutely support national commissioning, but with local flexibility though as well. Pharmacy 2 would be able to support any commission service. We have experience with providing commissioned sexual health services as well, within London and across the UK, across England, sorry. So yes, we'd absolutely support it.
Yeah, similarly, we would welcome the conversations to co-create and establish a commission service that will work through community pharmacies and as I say, give people access to this type of treatment and care in their communities, delivered through community pharmacy.
Do you have a model in your mind of how that service would be designed in terms of the way you operate?
We have introduced an in-pharmacy prescribing service in recent months, and we will roll that out. It is private pay because that's we don't have a commissioned service to offer. So we have plenty of experience in learning, and we work with government regularly on the design of services that work in community pharmacy. So we would have a model that we could share that would that could be commissionable.
Well,
absolutely. I think the important point would be to design that in partnership with existing providers. I think if done well, that can form part of the growth agenda. I think if this is done as a static one-off national commissioning, then we risk blocking new innovators, which then reduces the growth agenda. So I think a national commissioning in a dynamic way that enables digital providers to showcase what they have and enable local choice, but without too many barriers in terms of multiple competitive tenders for innovators, I think could actually be a big piece of this solution.
And how could the funding work, and how could that be improved for a nationally commissioned service?
It's a really difficult question. I think if it was easy, we'd already have a fantastic nationally commissioned service. I do think that my recommendation would be to consider how cross-government departments can come together to tackle this from different angles. Part of the I firmly believe different government departments can seek benefits from treating obesity, whether that be reducing absenteeism, reducing long-term sick leave, reducing long-term conditions. So I think pooled funding and rethinking how we actually commission it could really help.
I think there probably is learning from existing commission services, as I mentioned about the sexual health side thing, but there is others that exist as well, so there's most likely to be learning from there as well. But I don't have the answer, I'm afraid.
Fair enough. Okay, well then, moving very specifically to you, Ms. Nevinson. So could you just tell me about what the decision making, what the thinking was to pilot an in-store service? What was your thinking behind that as a company?
We have a track record of delivering private services within our Boots pharmacies. We have successfully delivered weight loss services specifically through our online Boots Online Doctor service. And we recognise that there is an opportunity for people who are perhaps not able to access digital services to access this care. We also have a growing capability within our network of pharmacies of independent prescribers who are perfectly placed to be able to train to deliver really holistic care to patients, particularly in conditions like weight loss. So it's, I think there's room for both. And we wanted to give people the opportunity to access these types of services in pharmacy. The beauty of the face-to-face consultation is that the pharmacist can also talk to the patient about other conditions that they may be. Typically people living with obese will have other issues and concerns as well. And of course we're perfectly placed to be able to support with side effects, with nutritional advice and everything else. So we knew there was an opportunity there to do face-to-face, and there's definitely room for both. And we're seeing different types of patients offering our in-store service compared to our online service, so that kind of proves the point.
May I just
of course.
add to that? I absolutely support Claire and what she's saying there, and it's having previously worked with Lloyd's Pharmacy and Lloyd's Pharmacy Online Doctor. Similar models have existed in the past as well. For example, with the Gardasil 9 vaccine, HPV vaccine, is that there's a portion of patients who will be not wanting to have a digital consultation but want access to this. Is not freely available on the NHS at that time, and so having that access in the community and digitally provides a great access to the patient, basically.
Thank you. And obviously I think you've only started this in February, but what's your sort of anticipation of demand, and in the short time that you've had, is demand meeting that expectation, or is it below or above the expectation you had?
Demand is growing, and it relies on people knowing that we're offering the service. So there's more work for us to do to invite people in to access the services in our stores. We're seeing the demand as we would have expected for a pilot of this size. And by the end of April, we will be in 75 pharmacies, and we intend to roll out further after that. So we expect to see the demand will increase, just as it has done with the online services.
Are you able to give me any numbers on that?
I don't have the exact numbers to hand, but I'm happy to share that with you afterwards, if that's okay.
That'd be really helpful. A final question for me then. So, again, what we're trying to do is work out what can the NHS learn from all of this. So, from your in-store experience, what do you think the NHS could learn from those pilots? And has there been any input, either from their side or yours, to share that information to improve NHS services?
So we, as you might imagine, regularly speak to the NHS and talk to the policymakers about the services we provide, and we're always willing to share the information or thought leadership or data to support the development of commission services. We have, like Kieran said, we have years of experience of delivering commission services through community pharmacy, so we would expect, we would like to be able to take our private service and share that with the NHS as a model that could be commissioned. It's being developed in that way, and the success of other services that we provide through community pharmacy, Pharmacy First, hypertension case finding service, it's another service that really fits into the services that pharmacy already provides, so it makes sense for it to be commissionable. And it's
Thank you.
brilliant.
Thank you very much.
Very much. Danny Beals.
Morning. Nice appraisal talks about the importance of wraparound care associated with the treatments, and the NHS England implementation proposal talks about a number of different appointments that would be required. I think it might have been, Simon, you touched upon the number of GP appointments already. What does the wraparound care offer look like for your patients as part of the service you provide? I don't know who wants to go first. Kieran, and we've left.
Yeah, absolutely. We offer a structured clinical pathway. Every patient goes through a full clinical consultation. We have a multidisciplinary team, nurses, pharmacists, doctors, nutritionists as well. So there's ongoing support. The patient is able to...
All included, that
yes.
nutritionist, etc., that's all included in the cost up front?
Yes, so if patients want to access, we have a patient record. Patient can access that record at any point. They can ask the questions that they want to. We offer lifestyle guidance and advice during the consultation and post-consultation as well. And then there's follow-up with the patient after 2 weeks as well. Whether they respond to the follow-up is different, but we offer the follow-up.
Is that one-to-one support or kind of signpost?
Through their patient record, but yes, it's one-to-one. Yeah, absolutely.
Human
Yes.
interaction.
That's right. Well, it's digital human interaction, yes. It's through the patient record. But and then on top of that as well, we're expanding our wraparound service even further. So we have a partnership with Reset Health, which is a NICE approved support wraparound service. And we'll be working closely with them to enhance what we have at the moment.
And Claire?
Yeah. So patients who access our online weight loss treatment service are offered as part of that service. Everybody's offered a wraparound care, which includes live webinars, podcasts, resources, information, and access to a clinician 7 days a week. So if they have any queries or questions, they can use our chat functionality to contact somebody and they will get a response pretty quickly. We also have an app which we encourage patients to sign up to, which gives them just regular sort of nudge advice on lifestyle, the importance of nutrition and exercise, etc. In addition, people who access our service for the first time have to collect their prescription from a Boots pharmacy. So there's that additional opportunity for the patient to have counselling directly with the pharmacist, and again to access any support that they need through the community pharmacy setting. And then we obviously keep in touch. They stay with us for typically up to 9 months at a time, and we encourage them to stay with us so that they have that continuity of care.
Yeah, for sure. So just pointing out at the beginning of my answer, I'm representing 5 different organisations today. However, one of the pillars in our code of conduct is around that ongoing care, and the baseline, even though the wraparound care may vary from organisation to organisation, is ongoing medical support or clinical support. So patients similarly have access to side effect support, titration support 7 days a week. Some organisations have hotlines, some organisations do that via messaging, and it varies by patient choice as well. The other element that all of our organisations supply is education and behaviour change. So that can be in different formats depending on which company. So that could be webinars, it could be one-to-one health coaching, it could be an exercise programme, but all of those programmes include nutritional support and exercise support as well.
And the extra support you provide, is that all benchmarked into the price? There's no additional pricing, are there additional options you offer to people with varying prices attached?
We have everything that I've described is part of the package that everybody gets. We have an additional one-to-one coaching service that people can then add on as an additional to our main service as well. And people have told us that they have had really successful weight loss journeys with that additional one-to-one coaching. So that's also an option if people choose to use it.
How much is that?
If they tag it onto the treatment pathway, it's £32 a month, and if they choose not to use treatment but just to go for coaching, it's about £40 to £42. I'd need to double check that exactly, but it's around about that.
And Kieran and Simon, is there any similarity in additional structure pricing options depending on the level of support, or is it just one flat?
So I believe, again, I'm representing 5 different organisations, so there may be variability.
Juniper or...
So there are extra options, and they may include blood tests as well for some patients to be able to understand what's going on inside their body as well, and that's included at a slightly higher price or as an option for patients to purchase separately. And that will then also include an ability to go through those results with a clinician and get some real valuable
Those
insights.
blood tests clinically indicated? Are they recommended as part of the normal treatment pathways?
I think as a GP, I would argue anybody who meets the criteria, which all of our patients do for medication, would benefit from screening for things like cardiovascular risks, cholesterol, diabetes screening. So as a GP, if I was to start somebody on these medications for weight loss, I would be doing those baseline bloods.
And if any of those issues come back kind of indicative of potential low risk or higher risk or diagnosed conditions, what happens to the patients then?
Yeah, really fair question. So we have really strong clinical protocols in place, and we have a strong clinical team as well. So all of our results are viewed by our clinicians, and we have clear escalation processes as well to senior doctors, and then we work with patients to manage them in the best possible way, whether that be directing them back to their NHS GP.
Yeah. Would that lead to additional services that you would provide and charge for, or would that?
No, not at this stage.
So just refer back to the NHS to deal with the issues?
Lots of the things that we identify are things that patients can actually action themselves, and I would be mindful to point out that these are patients who are on a medication, so we may expect their blood tests to improve over time anyway. If we identify anything that's dangerous, that's beyond the scope or appropriateness of a digital model, then absolutely we would refer the patient to their NHS GP.
Thank you. And I think Kieran, pharmacy to you in your evidence suggested that your sector could provide these services for £300 a year compared to £1,200 a year, I think, in the evidence that we saw. What drives that price differential?
It's a different model of care. It couldn't be a like-for-like comparison with the NHS, because digital does offer the scalable, efficient ways of working. So clinically focused pathways. We ensure that our practitioners, so mainly independent prescribing pharmacists, but as I mentioned before, nurses, nutritionists, they're working to the top of their skill mix, and that then frees time for, say, the doctor who can deal with more complex clinical cases as well.
Is there a sense that you're kind of underpricing, that you're seeking to present quite a low-cost option, perhaps cutting back some of the? I think it's not saying necessarily that this is what you get on if you go straight to your GP, but I think NHS England's guidance talks about the need for 5 psychologist sessions, and we've certainly heard in our evidence from people using the services that they would value more mental health support, they would value more nutrition and dietitian advice, not necessarily that people want. Some people just want the medications, obviously, to get on, but in terms of longer term change, in terms of sustained change, actually kind of brought, not just a inject and go model is needed, but a kind of properly sustained investment in people and lifestyle change.
I do agree. We don't advocate for, as you mentioned, a jab and go type model. I couldn't comment exactly on the figures here. I'm sure we can follow up with that. That's no problem at all. The challenge that we always have within general practice, again, this is not a new model. I would diagnose someone with diabetes, I would be referring them on to a wraparound service, a Desmond scheme, for example, when I was in practice. The engagement from the patient is something different. We would absolutely inform them of the benefits, the risk, the importance of carrying on with the wraparound service, but it doesn't mean that we can't mandate that you have to have wraparound service. So you're right, it absolutely shouldn't be a jab and go service, but not all patients will want wraparound. These are very well educated patients. They have been dealing with this chronic condition for a number of years, and have been trying to fight against it for a number of years. And so they know what their options are. Often the things that we offer around in wraparound are things that they have done already. And so they think that, actually, I'm not sure that this is going to support me further. I'm not sure I agree with that, but that's some of the patient behaviour that we've seen.
And how, perhaps a question for all of you, how do you monitor engagement and take-up in the additional services you provide? Are you confident that the videos that you're providing, the consultations, that they're actually being utilised by the patient? We've all done online HR mandatory modules where we kind of click very quickly to get through, to get it ticked off, potentially, myself included. But how confident are you that the safety advice you're providing, the guidance, the webinars, the videos, are being used by patients?
So I can speak for Juniper specifically, and I don't have the exact numbers, but we have published a peer-reviewed paper on this, where we've split our patients into different cohorts of engagement, and we've defined that in terms of their interaction with the wraparound care, basically. And what that paper showed was those in the most high engaged group actually achieved much better results than those in the lower engaged groups, and we can forward that on if you'd accept
Please,
it.
yep.
Yeah, similar. We've done a similar thing. We can see how many people are accessing digitally. You can see that, can't you? You can see how many people are watching the webinars and engaging with the podcasts. And we know with our specific coaching service that patients lose more weight more effectively if they engage in coaching. I think the job of work for us all to do is to educate the public. You can't force people to do these things, as you say, but we need to help people really understand the importance of it. So it's about offering what we can and encouraging and educating and coaching and counselling people to engage in the wraparound care, because we know that that really matters.
Can you do that in a light touch model of prescribing? I guess that more sustained engagement and change, kind of behavioural change, perhaps dealing with some quite underlying issues which are quite deep-seated and long-term. People might be battling with, as you say, different diet and exercise programs, mental health issues, personal issues. Can you do that in a £300 model where you get some online webinar options and maybe you can chat with someone in a chat room function?
Yeah. So I think obesity is a complex condition, and people living with obesity, as you say, have typically lots of other challenges that they're living with. Our job is to give them easy access to the support and to educate them through the journey, to provide them with access 7 days a week to a clinician for whatever question they might have, to encourage them to come into community pharmacy to talk to a healthcare professional when they need to. You can't force people to do this, but you can encourage them to. And I think the benefit of the GLP-1 treatments is that they experience weight loss successfully, more so than they might have done with everything else that they've tried before. And that, what we found with our patients, is that gives them confidence, gives them hope, and it gives them, they're more likely to feel engaged because they're seeing the benefits. So I think I can't comment on prices of different services, but certainly that is our approach, is to really stress the importance of lifestyle and engaging in the support that we provide.
We've certainly heard, I think Juniper, you also mentioned, I think twice as likely to achieve weight loss in the model, at your point, Claire. What evidence do you have about the long-term and sustained impacts of your approaches around weight loss? I guess this is one of the common questions about these interventions of GLP-1s. Are you seeing a year, 2 year, 3 year data at this point, and what does that show compared to traditional prescribing models?
So I think in this entire industry, that's something that we're all really keen to learn more about, whether that be from an academic point of view, clinical, or society. I don't have the data right now, but it's something we are conducting at the moment as a research piece, absolutely. I'm not sure if we will have preliminary results by the time this committee needs it.
You'd be interested at any time you
anything.
get them, even if it's after we've published.
Okay,
yeah.
perfect.
Do you obviously the study data collection is underway. Do you have any sense?
Preliminary results. I don't have anything that I'm able to share at the moment, unfortunately.
I guess this is the billion-dollar question: is, you might, with a low-touch model where you can get people access quicker, see weight gain quicker, but can a light-touch model keep it off longer?
Sure, and I think this is a really important question, and we do really need to have the answer for it. The way I frame this when I have conversations with patients is, if you were to do a really good diet with no other changes for 6 months and then stop that diet, absolutely your weight would regain. So I think it's important to note that GLP-1s are not a silver bullet. They are a big piece of the puzzle here, but I do firmly believe that if we're using patients' positive experience of weight loss to instill behaviour change as well, then my hypothesis is that is going to have a positive impact in the long term.
Are you collecting any data which indicates that you are achieving behavioural change in terms of diet and exercise?
We have lots of anecdotal stories. So, for example, and I'm sure the other organisations do as well, and I can collate some if it's helpful.
I mean, if any of you had data based on what your patients are kind of sharing with you around that behavioural change point, I think that would be very interesting for the committee to see.
Would you accept qualitative data?
Yes.
Yeah, absolutely. We can collate some. We have a moderated peer support group that patients are very keen to share their stories of things that they were unable to do previously, but now they are able to do because of lifestyle changes that they've made. So we can collate some stories for you.
Thank you. I'm just conscious of time, so I wanted to touch a bit more on the kind of data sharing issues, which you also already touched upon to some degree around access to patient records. Can you kind of briefly talk about what generally data you do have access to around patients at the moment? Is it kind of variable, place to place, GP to GP, patient to patient? I don't know if anyone wants to start.
It will vary from provider to provider. So independent providers, and this is very general, will not have access to the GP record. And so you are taking history from the patient and making a clinical assessment as you would do in normal general practice, but you wouldn't have necessarily access to summary care records from that because that's prohibited, as Simon mentioned beforehand. It's a risk, and I'm sure you're aware of that. It's a risk that has existed within the system for quite some time. For example, in an insurance company, you can get a GP referral internally within the insurance company to a consultant, but not have access to the GP record there. And as Simon mentioned before, a private GP. So it's a known risk, and I think it's becoming more prominent because of the demand.
None of you at the moment in any locations would have access to any.
Some CORD members do have access to summary care record. There's only a small number of private providers who are granted that through a pilot programme.
Mm-hmm. In terms of risk around that, and obviously trusting the data you're being given by the patient, do you hold that risk? Are you responsible for that risk?
Yeah, ultimately, yes, if we're providing the care, but that's why we have really multi-layered processes to verify the information that we receive. So if patients are meeting eligibility based on an associated condition that they're telling us about, then all of our member organisations will request proof of that. We're very keen to not increase NHS GP work, so that may include patients uploading their own NHS information, for example, from the NHS app or from their repeat prescriptions, and then one of our UK registered clinicians will verify that manually through the photographs and cross-reference with the patients.
And it goes the other way as well, is that we should be informing the GP of any medication that we have prescribed, as you would do in, say, a consultant private consultation.
That's standard practice. The GPs will be.
We operate on a consent-based model across the group. Different organisations may interpret that differently. So some organisations do automatically inform general practitioners. However, some operate on patient consent. And again, that's similar to how a NHS sexual health service might prescribe very high-risk drugs in terms of needing monitoring, but the NHS GP may have no idea because of the patient's consent. So it's an inherent risk. It's not unique to digital or private providers, but it's something that we have processes in place to mitigate against.
Can I just interject? You mentioned a pilot programme. I don't think we're aware of this pilot programme. Would you send us some details about it?
The summary care record?
Yes, yeah.
Yes, absolutely. We can send you the information.
That would be really helpful, yeah. I don't think we've got that. Sorry, any girls?
Thank you, Chair. It's helpful. Are you aware of any instances where the incomplete records or medical records has created any issues around prescribing or complications or any challenges for any of your patients? Has that been an issue?
I can't think of specific examples or talk to specific examples. However, across all healthcare settings, we operate in risk. That's why healthcare professionals exist, to be able to help patients navigate the risk and benefits and make choices that are correct for themselves. And again, that just to reiterate the point, that's why we're really strong on our multi-layered processes of making sure we have the right patient, making sure that we're happy that their BMI lines up with what they've told us, making sure that we have as much information as possible to reduce that risk.
And I understood from your earlier discussion that you're keen to get wider access, kind of having the single patient record, kind of access in future to, is that your general position that would be helpful?
As a GP, I will always welcome more information. The more information, the better, and it would certainly reduce friction, both for the patient and, like I say, because ultimately we're asking patients to do that work for us in the meantime to provide that proof, because we will not prescribe without the satisfaction that the patients meet the criteria.
Are there any, so you lent upon sexual health services, as an example, in a couple of you have. One of the common complaints in sexual health services is that there's inappropriate testing by private providers that wouldn't be recommended, and increased referrals to the NHS through inappropriate tests that are conducted. And this can also be in other private genetic tests, other things which aren't clinically indicated that the private sector often do, or types of tests that aren't recommended. And also secondary, that the private sector cherry picks the easiest patients, the most educated, I think you talked about, for profit, and the more complex patients, or if there are complications, they're then referred back into the NHS system. Do you recognise any of those concerns and questions in this potential space if the model develops further?
I understand where the concern comes from, and it's probably myself who's lent on the sexual health analogy, and that's because I used to work in sexual health, so I'm just very familiar with it. In terms of the question around whether things are indicated, all of our organisations do things that are in a patient's best interest. So that, as I mentioned earlier, the tests that we may offer to patients would be clinically reasonable to do so. So I think that's where I would stand on that point.
Do you have any data around the number of patients that you will refer back to the NHS or their GP about matters that you've looked into, tested for, border support? I mean, if someone was struggling with their mental health, referring back, I'm not saying you shouldn't do that, but do you have any sense about the number? You've 250,000 people, I think someone said you were supporting here on GLP-1s. What level of additional referrals will come from the patients you're seeing?
I don't have that data, but as a group, I can go back to the other organisations and see if we can aggregate some numbers for you.
Be helpful. Thank you very much.
Thank you very much. So, thank you all for coming. I'm now going to talk about the people who probably would never have come had we even asked them. And these are the unregulated prescribers and people who are doing inappropriate prescribing. There is huge public concern about this. I've taken a particular interest in it, met families who have quite literally lost loved ones to receiving illegal jabs. And we have had disturbing evidence from organisations like Pressquip, who talk about people being prescribed jabs to attain the bikini body. They have a history of anorexia. They've also raised concerns about post-pregnancy, especially with mothers who are still breastfeeding. I mean, obviously counterindicated by any of the license, but nevertheless, they are getting them anyway. What more needs to be done to ensure that organisations that are prescribing to the licence aren't inadvertently tainted by those who aren't? And can I urge you to not hold back? You are covered by privilege, as we are in these sessions. Earlier you declined to talk about some people who you might be aware are doing this. Please don't hold back. Privilege means that you can speak freely. Because if we don't get to the bottom of this unregulated Wild West market, everyone is at risk, in some cases fatally so. Can I start with you, Dr. Kieran?
Yes, of course. The challenge that the regulators face is that the scale of innovation for digital providers is so fast, and there is a lot of funding that's behind that as well, and able to provide the types of models that we've been talking about beforehand. And it's difficult for the regulators to keep up. And we do have engagement with them. Similar sort of coalition that Simon mentioned before is DICE, Digital Care Excellence, which is an industry forum, regular interaction with the regulators to inform them of what, dare I say, good providers feel is best practice. And so we should be working closely with them on what those guidelines should be looking at. The challenge that they face is the speed to be able to look at all of the unregulated providers that there are out there. So that could be from a GPhC perspective, pharmacy perspective, or from an MHRA perspective as well, and getting the illicit drugs. My personal concern as well, which may not be shared across the group just yet, but we have just seen semaglutide, Wegovy go off license in places like India. And so this is going to be manufactured on a wide scale. And so, not that it's a dodgy drug, but access to that illicit market may increase then as a result of it. And so are we going to see more of this, and are the regulators ready for this? We've seen it before. We saw it with PrEP. PrEP wasn't freely available in the UK, and even healthcare practitioners were advising patients to get their medication from abroad and get it posted over. So we've got precedent there that it is going to happen. Less likely so because it's cold chain, but that may be removed in the future. So it makes it more difficult. So I would say it is a regulator challenge, without doubt, and the resource there and the engagement.
The regulator, I'm looking for specific things that we need to be recommending to government to get ahead of this, because right now we are way behind, aren't we? Yes. I mean, way behind. And the number of families and people who are now affected by this, young girls who are, finding a way, and I'll come to how they do that in a moment, but they are finding a way to get this, and they are getting it illegally from abroad, and some people have died. I mean, we are so what concretely, give me three things that you want to see the government do, whether it's more resource to the MHRA, that's one I heard, what's another two?
It's across all the regulators, I would say.
All of them,
The regulators keeping up to date with digital practice, we're going to see more and more things like artificial intelligence, etc., coming across the board.
Yeah, I'm coming back to that,
And they are not keeping up to date with that as far as I'm aware. Those are my top two, I would say.
Two.
Yeah.
Yep. Claire,
I think what's really important that we can all do is to cut through the misinformation and cut through the noise and the social media by providing better information for patients. So we're educating the public to identify what's the right way to access weight loss medicines and what isn't. So we need to help the public understand and to identify where they're finding this information and to nip it in the bud through the regulator. But we need to be able to educate people better about obesity, about safe weight loss. And we all have in our organisations channels to be able to talk about these things responsibly, but we need the government to help us to really bring to the forefront.
What specifically do you want the government to help to do?
Better patient and public education on safe weight management services.
Isn't one of the issues here that the way we see obesity is almost like a beauty issue rather than a medical issue? And many of the people at the round tables that we heard wanted us to, I think, Kieran, you called it a chronic condition earlier, and one of the conversations we've been having is, should it be called a condition or a disease? I mean, would you all agree that it should be classified by government as either a condition or disease, or either or? What's your preference?
That would be my third thing.
That would be the
I would
third.
stop talking about weight loss drugs and talk about obesity.
Obesity as a disease?
As a disease.
Or
chronic
do you
condition.
prefer condition or disease? Which one do you prefer? Does it matter?
I don't think it depends how the public will relate to it, I suppose, and
Yeah,
understand it.
I think the patient voice is really
condition.
important in that, because I think we've probably fallen down that track previously with things like chronic kidney disease, and that causes problems for patients in how they interpret their own conditions. So I think involvement from patients rather than just us as providers would be the important missing bit there.
How about you, Sam? What else
What
needs
concrete
to happen?
things? Just
concrete things.
To build on those, I think avoid broad brushstrokes. So avoid tarring us all with the same brush. I think really working with responsible providers to be able to build proportionate and effective evidence-based regulation so that we can do things correctly, which leads into your point, Claire, around making sure that we're putting out proper and reasonable information so that patients have an alternative choice. If providers like ourselves are removed from that conversation in contemporary media, whether that be online or adverts, then that only leaves space for bad actors who will fill that gap, and patients will still find a route to that. The recent report from Lilly and Patient Association a few weeks ago showed that the number one reason patients are choosing the black market is because of reduced access. So my concern would be that regulation falls on the wrong side of responsible and shuts down the opportunity to provide responsible information and access.
Yeah. So let's get to the AI point. And one of the ways that we know that people do get through the various gateways is that they are able to manipulate digital images. It's much easier to manipulate a digital image than it is, well, I've yet to work out how to make myself look skinny in real life without some kind of filter on everyone else. So this is the big issue that I think we are concerned about currently. How are we going to get ahead of this? So in your own organisations, you've given us evidence about what you do. Pharmacy 2, you spoke about sophisticated algorithms that gather the complete medical history and then scan. Can you just give me an example of how exactly those algorithms work? Just one example.
We're talking about verification or the clinical
so
assessment?
to get it in the first place. I mean, let's focus on just that very first prescription. How does someone access it? What does that algorithm do exactly?
The structured clinical pathway is basically where the patient would be, if I was doing a history for a patient, one answer would lead to the next question that I would have. Our algorithms work in a very, very similar way. Mm-hmm. The most important thing I think you touched about, which I feel very passionate about and have been for years on this, is around the identification side of things. How do we know who we're treating? And so robust verification is important there. And then as far as the body mass index is concerned, we only do video verification, so real-time video verification where the patient has to upload it live. There is no ability to manipulate it at all. And so we have not come across the issues which I know some other providers have had with AI manipulation.
Did you always do that?
Yes.
Yeah, but Boots didn't always do that. We understand, was it Which looked at how people could access the consultation, and it was a upload of a photo. So has that changed then?
Yes, it has.
Okay,
yeah,
good.
So similar to the use. So technology allows us to introduce better safeguards. So we have exactly the same. So live photograph upload, so that can't be manipulated. We've also introduced.
Oh, wait, hold on. Live photograph upload.
So you've got to take the photograph live and upload it into the system, just the same as Kieran has described. So you can't take an image and modify it and then upload it.
Oh,
it has to be done at the time, so it's real time.
It's done through your app or whatever, and so you can control whether it's.
We also have an additional safeguard because certainly for people accessing for the first time have to go into a community pharmacy, and should a clinician from our online service have any queries or concerns about a patient's BMI, then they will be asked to weigh them again in pharmacy. So we've introduced that as an additional safeguard as well.
Thank you. So.
Yeah, and similarly, just to be really clear around the difference between video and live photo, all of our organisations have also implemented live photos to reduce the chance for patients to be able to upload from their gallery or a photograph from 2 years ago or something that's been edited by AI. So all of our organisations, you have to open the camera within the flow of the app or the website and take different photos there and then. Mm-hmm. If there's any, so that can't be modified by AI. What we've found is it's different to having a live video with somebody FaceTiming, for example. However, we find that to be safe because it reduces or eliminates the chance of AI, and that's the type of thing we want to work with the regulators so that they really understand the nuance of digital health and introduce proportionate and appropriate regulation.
Thank you. I'm just going to, Simon, while I've got you, Josh Fenton-Glynn had an aside.
Yeah, just a couple of things. So your coalition represents what you're referring to as the responsible pharmacists, which I assume means that they follow kind of both the letter and the spirit of the various regulators' guidance. Is that right?
Correct, yes.
So I was a bit confused because the Advertising Standards Agency obviously doesn't allow direct-to-customer advertisement of prescription medication. Is that correct?
Of prescription medications, yes.
So when I Google weight loss drugs, one of the sponsored results is Newman Pharmacy, which is one of your coalition, right? And it advertises on the basis of a discount for the initial few months that people do it. It says the headline when you Google is now £55 was £139, lose weight from £55 a month. Do you think that actually is following the spirit of the guidance?
So I think the thing to be mindful of is all of our providers are offering a service. We're not a transaction. We're not offering a medication and then no further follow-up. I think if there's any concern that any breaches have happened, then we all have processes in place to redact any adverts that the ASA are concerned about. And again, we're very happy and want to work with the ASA to get that right.
So you would wait for the ASA to flag it rather than, having concerns about what appears to be direct-to-customer advertisement when you when you Google weight loss drugs?
In terms of advertising a service, I don't think there's any breaches in advertising a service. The concern is around advertising medication, so I'm not sure of the specifics of the advert you're referencing, but if there's any concern that that's advertising a specific prescription medication, then that should be redacted. But if it's advertising a service, this is the type of thing where we want to work with the ASA to make sure patients are informed of reliable providers who are regulated, rather than being pushed down alternative routes.
Okay, thank you. And my final question before we move on, Kieran, your written evidence suggested that we need stronger action to prevent unregulated operators. We kind of talked about the top three, but should we just not be taking a much more cautious approach to this, where someone has to prove that they are doing things properly, otherwise they are not allowed to be selling these drugs? And that would make it so much easier for social media companies and the advertisers to know who to allow to advertise and who to allow to sell it. At the moment, what it seems we have is a market that is rapidly innovating, but with a potential, and we don't even know the size of the unregulated market, but by the sounds of it, from the number of whistleblowers and stories that we're getting, it is potentially huge. I don't know if you guys have done any work about this, because it's a direct issue, I would imagine, for your companies, and we'd love to hear it if you have. But should we not just be taking an ultra-cautious approach until we've got to a stage where we know what it is that we're doing and we can properly safeguard people?
Could you clarify ultra-cautious for me? What do you...
So, you know, you get you would perhaps have well, I'm looking to you guys. At the moment, we've got the default position for a consumer is that anyone who is able to sell this is doing it in a way that is right. And actually, if you had much fewer people doing it, but with a much stronger kite mark endorsed in a way by government, and then they'd be able to sort the wheat from the chaff. At the moment, there is so much noise out there, and there is so little access that they're getting it from anywhere and just assuming that it's a medicine and is therefore regulated, and that's the end of it. There's a lot of onus, and I think, Claire, you mentioned this about education on the public. I'm wondering if that's fair at the moment, because there is so much that is new that they're going to the first place that seems to be doing it well. So what would you say to that?
So I would say, in principle, I would agree. I would go back to what Simon mentioned beforehand. It's not a broad brush approach, and actually working with government or working with the regulators on what that looks like. Who, as in a good service, is what's best practice basically within the digital healthcare field, because we are the experts. We have been doing this for a number of years, reputable providers, I mean, and so. We should be working together to see what that looks like, and unless you meet these certain criteria, then you shouldn't be practicing. Yeah, absolutely, I would agree with that. That's a challenge, and we don't...
What about it is challenging?
The acceptance of innovation. So where we worked with regulators in the past is because the advisors are not necessarily very well informed about the type of work that digital healthcare providers do. They can go more conservatively, whereas, as I mentioned, we've been practicing for 20 years. We know what's safe. We have good risk analysis, robust clinical governance around it. As long as that clinical governance exists, and we could advise the regulators on this, then I think the risk reduces.
You think the regulators are too cautious, and by being too cautious, they're not allowing the innovation, which would be safe, to increase access, which itself is the thing that's going to make it all safer.
Yes.
Have I understood that correctly?
Yeah.
Thank you. Claire?
So I think we have definitely moved some way in this space, particularly with the GPhC and the CQC, who regulate our services. The GPhC have issued standards for online pharmacies and for the provision of services like the services that we're talking about, so the rules are there, the standards are there. We have challenged them, we've co-created them, we've presented examples of good practice, and we've done that as a collective through the Digital Clinical Excellence Network. So I think the regulators are definitely learning and trying to keep up with the innovation. The challenge that they have, to your point, is that there's such a rapid rise in people setting up services, and it's resource, it's capacity for the regulators to catch up with them. What we do on a regular basis is meet with the regulators as a group, and we will tell them where we are seeing or we're picking up poor practice or it's been reported or we've noticed it, we do flag it to them.
Do you know how many other companies you've reported?
Off the top of my head.
Can you get us that number?
We can have a look at that for
And
you.
even better, write to us about who they are. Could you do that?
Yeah.
And could your coalition do that too?
Yeah, I can speak to the coalition.
That'd be very, very
It's helping
helpful.
the regulator understand what's good practice and what isn't, and being really clear at helping them on this journey of understanding how technology is evolving and how we need to use it, but actually, as you say, taking quick action when we have a concern.
I think it's the quick action. I agree with that.
Quick action. So I'm hearing resource as well. Yeah. Okay. That we have to end it there because we've got to go speak to the regulators. Thank you very much. Panel 1, can I ask panel 2 to come up, please? Thank you.
Thank you.
Panel 2, welcome very much to this hearing. Thank you also for being in the room and hearing, I think, most of it. So can we start with who you are and your organisation? John, please.
Yes, hi. Good morning, I'm John Spoors. I'm the Programme Director for Commercial Managed Access and Medicines Policy at NICE. Lovely to be here. Thank you.
Lovely to meet you. Neha.
Hi, I'm Neha Ramaiya, Lead Clinical Advisor at the GPhC.
Andy.
Morning, I'm Andy Morling. I'm Head of the Criminal Enforcement Unit at the Medicines and Healthcare Products Regulatory Agency. Good to see you all.
Very much. To kick us off, Dr. Becky Cooper, please.
Thank you so much, Chair. So thanks, panel, for being here. I'm going to focus on questions around side effects and also around NICE appraisal this morning. So, Andy, if I can come to yourself to start with for the MHRA, GLP-1s, as we know, have a long-standing history. They've been used for more than a decade to treat type 2 diabetes, so we're well aware of their profile in that regard. In terms of side effects now that we're seeing for GLP-1s being used for specifically weight loss, is the side effect profile similar to the side effect profile you've seen for type 2 diabetes, or different? And if different, how so?
My understanding, it's similar, primarily around gastrointestinal, vomiting, diarrhea, constipation, those kind of things. Generally not severe, although that can occasionally be the case in rare cases. So broadly the same side effects, in most cases not severe. In exceptional cases, they can be severe diarrhea and gastrointestinal issues, but that's very rare.
Okay, so just to be clear, you're not seeing any difference in the side effect profile from a type 2 diabetes patient using GLP-1s to a non-type 2 diabetes person using it for weight loss. The side effect profile is reasonably similar. Yeah. Okay, so given obviously that GLP-1 products haven't been used as weight loss tools for nearly as long as they have been used for diabetes type 2, are you concerned about an increase in side effects being reported as GLP-1s are used more frequently for weight loss?
We've had many reports, and those are, one would imagine, to some extent related to the publicity surrounding GLP-1s for weight loss. We tend to find that when new medicines come onto the market or for new indications, that reports into us of adverse effects go up.
Okay, so just to be clear there, you're not seeing more side effect reporting for the new use of this established medicine than you would expect. It's within parameters, expected parameters.
There is no normal sadly. I wish I could sort of give you a bit more.
You do have data across a wide variety of medicines, so you can see the parameters of what you may expect.
We do, but to some extent this is a self-selecting audience of reportees. What we're getting are people reporting. It doesn't necessarily indicate prevalence, but we have had a high number, as I said, possibly because of the fact that this is widely known and now widely used. So it's hard to get causality from this data as well.
No, I appreciate that, and I appreciate the prevalence issue. And whilst obviously you can't take a sort of accurate indicator of prevalence from reporting, again, given the extensive licensing that MHRA has done over the years, the reporting that you're seeing, taking into account the self-reporting nature of it, the private prescribing of this medicine, is this broadly what you would expect to see in terms of the side effect profile and reporting?
It's not outside of the parameters.
Okay, that's helpful, thank you. So let's talk about how you are getting this information. So as we've talked about, there is currently large private use of GLP-1s, and we have the yellow card system to monitor side effects. Is the private use of GLP-1s having any effect on the return on yellow cards? Are you seeing other ways of it being reported in?
Well, we certainly encourage yellow card reporting regardless of the prescribing route. So we don't regulate prescribers, as you're well aware. So we would certainly encourage that reporting, and we do go out looking for it. We do encourage private prescribers.
When you say you go out looking for it, what do you do?
Well, we speak to the trade bodies to make sure that they're aware of yellow cards. We promote yellow card more broadly within the professions. So we encourage reporting where we can into yellow card, and we have seen that. I don't have figures as to the level, but certainly we do.
It would be interesting to see those figures.
Okay, I'll see if we can get them.
Yeah, and the yellow card reporting, I mean, it's been around for a long time, and there have been conversations about whether it's fit for purpose or whether they need to do something else. In your opinion, is yellow card reporting still the best way of sort of assessing side effects coming forward or adverse impact?
I think I'd probably say the least worst.
Right. We've heard that before.
Well,
yeah.
I mean, it is something that it is what it is, and I hate that expression normally, but it gives us access to information. How reliable that information is, what conclusions can be drawn from it is another matter, but I would certainly rather it was there than not.
Okay, and over the years, Andy, that's interesting, and we won't go down this rabbit hole too much, but over the years, the yellow card reporting system, by and large, have you found with your licensing of different medications that it is a reasonably reliable indicator of when there are issues that need to be acted upon?
Yes, I mean, it's certainly given us signals that we've acted upon in the past, yes.
Yeah. And is it Neha? Yeah. Neha, have you got any reflections on that from a pharmacy point of view in terms of monitoring side effects and how you're able to report in?
Just to say that in relation to the yellow card system, is that what you were trying?
Yeah.
So in relation to the yellow card system, as my colleague mentioned, that we have had conversations with MHRA about it quite recently as well, and not related to weight loss, but more broadly, we've included it in our emerging concerns letter, which was sent out in December to encourage pharmacy professionals to report any kind of side effects that they see. And then the last point in relation to yellow card that I had was our updated guidance for online pharmacies. We mentioned yellow card reporting within there, particularly because quite a few of the weight management medicines, and correct me if I'm wrong, are black triangle medicines, so they're newer to the market. And so with the extensive monitoring that is required, we felt that it was important to bring that yellow card reporting aspect to the guidance as well.
That's really interesting there. So in terms of online pharmacies, are you seeing a proportionate reporting to the in-person pharmacies, or are you seeing lesser reporting?
We would that's not data that we would directly have access to.
Okay, does somebody have access to that data?
I'm presuming the MHRA from...
I'm afraid I don't know, but I can certainly find out.
You can find out, that'd be really interesting, because obviously online pharmacies are becoming more prevalent and people are using them increasingly, so it is good to know if our reporting systems are fit for purpose in the digital world. That's really helpful, thank you. And if I can move on, John, to nice appraisals of these weight loss drugs, which are quite interesting, I would say, in terms of what the understanding is now with NHS provision. So for the record, obviously you have basically made a positive recommendation for the use of this medicine now. And I wonder, just for the record, if you could explain very quickly how you have come to that, making that positive recommendation for GLP-1.
Yeah, sure. No, I'm very happy to do that. So we've actually evaluated 3 GLP-1s, so liraglutide, semaglutide, and indeed tirzepatide, which you're referring to. So NICE uses, I'm sure committee members are aware, the QALY, which is a standard health measure that is, utilitarian in the way that it resonates with the NHS. So a QALY is a QALY whether it's cancer, whether it's multiple sclerosis, or whether it's...
Sorry, and just for the record, because the public are watching, John, can you just explain quickly what a QALY is?
Yeah, sure. So a quality adjusted life year.
Thank you.
So yes, and then what NICE does is it takes the evidence from the manufacturer on the clinical and cost effectiveness, and then our independent and transparent committees make a assessment of that evidence with an academic critique of the manufacturer's submission. And what we do is we weigh up the health benefits versus what the costs are and the additional costs. So I think today we've heard all the importance around of wraparound care. They're all included within the appraisal. We also look at things like the ability for weight gain to come back on post stopping treatment. That's all included in the cost effectiveness assessment. And then at NICE what we do is we have a standard threshold. So what we say is if it's between 20 and 30,000 per quality adjusted life year, that is a cost effective use of resources. So for all 3 medications we've been able to recommend those.
What did they come in at for the QALY?
For the cost per QALY, so when NICE looks at the independent committee look at the evidence, they take a number of things into account. So for the weight medications, they looked at the uncertainty of the evidence base. They also looked at the scale of the budget impact. So depending on what that sort of looks like, the committee can either go at the top end or the bottom end. So directly answer your question, for all 3 appraisals at the bottom end, the 20,000.
Very interesting, thank you. So just again for the record, basically once NICE make a positive recommendation, NHS service providers are required to make it available to patients within 3 months as a default.
Yes.
So, but there is an exception to that.
Yes.
So based on your recommendation, NHS England estimated that 2.8 million patients would become eligible to use Mounjaro within 90 days of the final draft guidance being published. And if all of these people presented for treatment in the first year it became available, the cost of providing this medicine and wraparound services, as you've indicated, would be £15.2 billion over 5 years. So just going back to your appraisal, John, how much did you take into consideration that particular price tag?
Yeah, for sure. So I think particularly at NICE, when we create our guidance, we're very cognizant of the impact that it has on the NHS. In fact, that's why we have a world-leading process. We involve stakeholders throughout, whether it's patient, clinical experts, and indeed NHS commissioners. I think.
Excellent, John. So what did your world-leading process think about £15.2 billion over 5 years?
Yeah, exactly. So this is why we worked with NHS England, and they requested what's called a funding variation. That's actually been used very exceptionally in our 25-year history. So it's only been used 4 times, and we published over 1,000 pieces of guidance. And for the scale of what you said there, the reason that a funding variation was put in place was to ensure that the NHS had a sustainable and manageable plan to not only manage the costs, but also the impact on services as well. As you're aware, with tirzepatide, that can be used in primary care, whilst liraglutide, semaglutide was limited to specialist weight management services. So
you came, sorry John, just because we're time precious,
Sure,
so you came to an understanding with the NHS England, which you've only done 4 times previously, that all the eligible population will be able to be prescribed Mounjaro for obesity within 12 years.
Yeah, and then crucially, I think what was important with that is we included a 3-year review period. So the funding variation had kind of 3 parts to that. It had a kind of 18-month period, then up to 3 years. And I think that 3-year period is important because the NHS England, what they were saying, they were looking to prioritise the patients with the highest clinical need, and I think they were looking to achieve 220,000 patients on treatment at that point. So that was what was agreed.
And now I understand that, but over the course of 12 years, the highest priority people who may not be high priority now, and I am surmising this, may well become much higher priority in those 12 years. So at that 3-year review period, if we've been reasonably unable to spend £15.2 billion over 5 years, at that 3-year review period, have NICE factored in the fact that actually, given we've not been able to address the issues immediately, the cost tag may be considerably higher?
Sure. So I think in that 3-year review period, there will be data available on the various models that NHS England are trying. There will be data available on the uptake of patients and indeed the costs, and all these things will kind of be factored into that kind of 3-year review period. I think the other thing to mention within that 3-year review period, of course, the market in obesity is not static, so we're expecting oral GLP-1s to come. We're starting to appraise those at NICE as well. So I think there's various sort of factors moving that will be considered at that 3-year review period.
Excellent, John. And I just wonder, at NICE, and I know that you do appraisals on all sorts of things, including other weight management programmes, prevention programmes, that £15.2 billion, has there been any comparison at NICE to the opportunity cost for investing that in other effective weight management programmes or prevention programmes?
Sure. So I think in terms of, there's something I think what you're getting at is obesity unique in terms of the size and the scale? I think absolutely, but NICE has a remit to evaluate all new medicines and new indications that come before it. I think it's a broader question. This is probably one where obesity does actually kind of straddle the two between public health and indeed treatment. And of course in our NICE clinical guidelines and indeed our quality statements we take a broader view. But I don't think within a NICE technology appraisal it's our job to kind of suggest whether that 15.2 billion should be spent elsewhere.
No, I appreciate it's not your job to have an opinion on that, but in terms of an appraisal, looking at the opportunity cost, so how much bang for your buck you get in other areas of obesity treatment, so other weight management programmes and or a prevention, is that something that NICE has looked at?
For sure. So what the NICE appraisal committee say is when they review it and they do take into account opportunity cost, they are saying that with the evidence provided in front of it for the drugs, taking into account things like weight regain, the NHS think that's NICE think that's a clinical and cost-effective use of NHS resources, taking into account opportunity cost as well.
So taking into account all the other things that could be put in place to prevent obesity, reduce obesity, that NICE still thinks that the £15.2 billion should be spent specifically in this area, or the opportunity cost is taken into account.
When NICE do appraisals, it's not just the opportunity cost within obesity. We look at the opportunity cost of the whole NHS, and that's why we have the cost effectiveness threshold set at 20 to 30k.
Okay. And the cost effectiveness appraisals that you have been talking about, you have taken into account the benefits, you've taken into account weight regain, and you've looked at that. Have you looked at individuals with more severe or more complex obesity and looked at the fact that the cost effectiveness may be better for those higher end obesity cases? And I think you've sort of alluded to this in your priority case, but just to be clear for the record.
Yeah, no, absolutely. Yeah. So when NICE evaluates a product, of course, you have the license from the colleagues, helpfully at the MHRA, and then they look at various subgroups within the cost effectiveness assessment. So actually, in our appraisal, again, tirzepatide's a good example, those with a lower BMI weren't cost effective, which is why our recommendation is for 35 and above plus one comorbidity. So that is actually built into the assessment. The other thing I would say there is if you look at NHS England's kind of implementation plan, again, the cohorts that it utilises, again, prioritises those with the highest clinical need.
Okay, and my final question around service provisions. So perhaps now coming to yourself, John's alluded to the potentially overwhelming nature of this around service provision, and I appreciate your pharmacy specifically, but does your particular area have thoughts on whether pharmacies and primary care, if you want to speak about it, is going to be able to provide this level of input for the number of obesity patients coming forward?
It's difficult to say because as a regulator from a pharmacy perspective, like the provision of medicine is coming from private sources mainly is what we're seeing, so it doesn't apply to NICE and NICE's TA. So yeah, it's difficult to say whether that would be the case.
Given the opening up, the 220,000 patients, that it looks like the NHS are saying, okay, we'll sort of move forward on a cost basis as an agreement with NICE. Are pharmacy providers going to be able to undertake some of that, do you think?
So it depends. So there's two types of the pharmacy provision is in two formats. The private ones, which we've heard from earlier on today, but there's also NHS provision. Yeah. So it's kind of dependent on how much commissioning goes towards the towards the NHS pharmacies, whether they can afford to provide those services, whether they have the right staffing, the capacity, training in order to deliver that. It is just dependent on the funding model that supports that.
And is that clear yet, the funding model?
No, I was just about to say,
Okay.
at present,
Right.
I'm not sure whether that's clear yet.
Okay, all right, that's really helpful. Thank you.
Very quick follow-up, Danny Beals.
Thank you for John. So we're seeing that India is now rolling out generic, I think, Ozempic. What assessment have you made, or have you got any general sense of what the availability of generics might mean for that quality assessment and the 15 billion price tag, and when that may be applicable?
Brilliant. Well, I'm happy to report I contribute to a biosimilar task force which works across the Department of Health, MHRA, NHS England and NICE. When the patent expires, the prices start to drop. So I think what's really important is NICE's guidance is a snapshot at the kind of front end of appraisal, but when a biosimilar becomes available or a generic becomes available, or indeed new evidence, clinical evidence for a product.
A sense of when biosimilars may be available?
I don't have that data to hand, but I would be able to get that
you write
for
to
you.
us when
Of
you've
course,
got
we'd
it?
be delighted
What
to.
sense that might mean for your 15 billion?
Yeah, so I think there's two elements to that. I think the availability of a biosimilar can, of course, produce potential cost savings, but then at the same hand, as I mentioned before, there's new oral drugs coming into the market that might offset that.
Yeah.
The other thing with is it liraglutide that I think is coming off patent? So I think the other thing to mention there is liraglutide's a once daily injection versus semaglutide's once weekly, and patient preferences come into account as well. So whilst the potential is there for savings for sure, again, there are things that might mitigate that. Yeah.
Okay, thank you. Jen Croft.
Thank you, Chair. So, John, if I could just turn now to wraparound care and NICE guidance on that. So during our inquiry, we've heard about the importance of wraparound care from those with lived experience and from a myriad number of professionals. And do you have any insights you can share about where the extent to which, I think it's quality statement 6 for obesity treatment, do you have any insights you can share about the extent to which these standards are being met?
Sure. So NICE doesn't collect individual sort of patient level data, but as we say, I think, when we put these quality statements out, both in terms of our quality statements and our clinical guidance, we regularly expect the kind of NHS to take those into account when making decisions, but we don't actually formulaically collect individual data in terms of like how that's being adhered to. The one thing I would say is that I think the wraparound care, as you've heard today, is very, very important, and I think that's why that's absolutely prominent in all our guidance, in all our quality statements, all our clinical guidelines, in terms of pharmacotherapy being one potential option, and the importance of the wraparound care to the holistic patient journey.
So if you don't collect the data on it, where does responsibility lie for monitoring the quality of that wraparound care?
Well, so I'm happy to take that back to NICE and write to the committee in terms of what the actual uptake of that kind of data is, and also adherence to that, if that's okay.
Be helpful. And is there more that regulators could do in this space, and what would be needed from the government to support that?
Yeah, I think it's a great question. I'd be interested in kind of colleagues' view. I think from our side, I heard from the previous session, from my side, I think, and a NICE's view, our view is that the holistic patient journey is really, really, really important. And to me, what really resonated in the last session was that importance of education. I think NICE is a evidence-based body, and I hope for our written submissions and hopefully what I'm talking to you this morning about that comes across. And I think education and what the evidence shows us is really, really important. I was very struck by some of the comments made earlier in session 1, and I think support from the government in terms of what the evidence shows and how we can get that education into potential patients in the NHS, I think is going to be really important.
You don't currently collect data around where the extent of wraparound care is taking place?
We don't, but there might be, I think as part of the review, 3-year review, the NHS we should be collecting data on the uptake, not just the drugs, the wraparound care, the uptake, what patients' experience are as well. So that will all be fed into the 3-year review of the tirzepatide appraisal.
I'm just trying to get to, is there a gap therefore in this sort of evidence base for this, as you're an evidence-led organisation?
Yeah, and I think the NIHR, National Institute for Health Research, also commissioned a study particularly looking at the implementation of tirzepatide. So I could certainly, in our written evidence committee, we can pick that back up as well. I think the only thing to say, and I think this is quite important, is I think that sometimes people assume that a NICE recommendation is a mandate to prescribe.
Yeah.
And I think that's really, really important. It's not a mandate to prescribe, it's a mandate to fund, and that should be based on the choice between a patient and the clinician. And likewise, our clinical guidance, whether it's a clinical guideline or a quality statement, is very much to help inform and empower clinicians to take the right decisions for them and their patients.
Okay. It's just, I'm just trying to get to the heart of whether you see that guidance being implemented when it comes to that wraparound care side of it. I mean, we obviously have data as to the use of prescribing, but not necessarily that holistic side. But it kind of sounds like at the moment you don't have data whether that guidance is being adhered to.
Yeah, I can't say today whether we've got specific data, but very happy to take that away as a question and come back to the committee.
That would be really helpful, thank you. And if we move on to more data-related questions, is there any data that you can share again around the extent of inappropriate prescribing? As I know that's something that has come up repeatedly.
I don't think that would be a question for me. That might be a question for the colleagues of the MHRA.
Any, the other colleagues?
We don't hold data on inappropriate prescribing per se either, but what we do have is data on the types of concerns that we might receive, but they wouldn't necessarily relate to inappropriate prescribing. Some of them are like related to customer services or other issues in relation to weight management services.
So it's based on, so it will be based on concerns being reported to regulators?
Yeah, so concerns reported, it's not just concerns, it's also information from our inspections as well. So concerns being reported by healthcare professional, members of the public, whistleblowers, anyone basically, anyone can report a concern to us about a provision of any pharmacy service or pharmacy professional.
Are you confident that data that you are able to collect from this sort of method, are you confident that reflects the accurate situation on the ground?
That's not the full level of what's going on the ground. It's just as a regulator, our role is to regulate pharmacists, pharmacy technicians, and pharmacies, and part of that includes fitness to practice and dealing with concerns that come through.
Are you taking sort of action to address inappropriate prescribing, or is there more that could be done in this space?
Again, as a regulator, one of the other things that we do is an inspection function. So we have an inspection function to inspect pharmacies as well. So our inspectors do inspect all pharmacies, but in relation to weight loss services, they will inspect pharmacies that provide weight loss services. They will gather information and evidence against the standards that we provide, and either pass a pharmacy that's doing it appropriately or fail them, provide improvement notices, etc.
Just to be clear, also online pharmacies, not just...
Yeah, also online. But any pharmacy that's registered with the GPhC will be regulated by us. But just to be clear and to make sure that the committee understands that some providers are not pharmacies. They are also registered by the CQC, and they're providing a prescribing service, and then those medicines are then dispensed elsewhere, possibly by pharmacies that are regulated by us. So there's different models of...
What do you mean? I'm sorry, I'm lost.
So online pharmacies are... Yeah. Well, you can get online pharmacies that are dual regulated by the CQC and GPhC, and that's because of the way the provision of the service is happening. So CQC would regulate the prescribing service, and GPhC would regulate the provision of the medicine. Mm-hmm. There are other services that are only pharmacies because they are provided by pharmacists and pharmacy technicians only.
Okay.
And then, of course, there's other services that are outside of the UK's remit, outside of our regulatory remit, because their service is provided by the EU. And those prescriptions then are legally valid in the UK, so the prescriptions are coming over. So the prescribing service itself is unregulated by any UK regulator.
And are you coordinating between you to make sure everyone's covered?
So we can't coordinate with the non-UK regulator, but yes, we work closely with the CQC and the MHRA and others.
Back to Jen, sorry.
Do you not feel that there's a bit of a... Is there not a gap then?
Yeah,
therefore,
there's a regulatory gap there,
yeah. And is there a risk that if the sort of UK online and offline market is regulated, that people will then opt to go elsewhere? Does that cause concern for you?
It could cause concern. It can cause, and it does cause concern. One of the things that we are doing at the moment is we're working on a social media campaign to help the public understand what the difference is between buying medicine safely, making sure that pharmacies are registered, showing them how to check that a pharmacy is registered. So we're working on that at the moment to help address that concern as well.
And are you, what kind of measures have you got in place to sort of address whether or not the actions you're taking are successful?
So, I mean, in terms of our concerns, at the moment, what we've seen is we've had like a steep rise in concerns between 23-24 year and 25-26 year. And generally, quarter by quarter, we've seen a raise in concerns related to weight management. We did see that dip over the last quarter. And the types of concerns we're now seeing as well off the back, and we presume this is off the back of our updated guidance for online pharmacies, is we're starting to see more concerns related to patients struggling to access, not struggling, but unable to access medication because they're being challenged on like appropriate weight and ensuring that their weight's appropriate, asking for more evidence about their history, etc., which is what we've kind of strengthened within our guidance that was published last year.
Is there a worry that people unable to access medication via UK online or offline routes are then going elsewhere?
There could be, but I mean, in terms of the UK remit, that's a good thing. We're seeing more concerns raised by members of the public that it's becoming difficult to access medicines because they're being asked the right questions. And that's so the concerns in terms of patients inappropriately being prescribed medicines, or there's patients accessing medicines because they shouldn't have received them, etc. With that has dipped slightly, and we're seeing more of the other ones instead.
And your kind of role in this space, are you seeing have you got any measures to measure success as to whether or not you're able to clamp down on inappropriate prescribing? And are there more regulations that you're looking to bring forward, or where is your...
So obviously the MHRA doesn't regulate prescribing practice, so that would fall to others. So there's a spectrum, if you like, we see when we're looking for the illegal online sellers of these medicines. So that's a very different thing. That's the far end of the spectrum, if you like. And then there's the genuine prescribers who are private prescribers at the other end of the spectrum. So what we see is a bit of a blurring of the lines between the two, where there are illegal medicine sellers purporting to be prescribing, when in fact it's just a front for an illegal online pharmacy. So there's it's difficult for the public to tell the difference sometimes between the two.
What do you think is needed then? Is the regulation fine and sufficient in this space, or is there something different that needs to...
Well, I mean... Inappropriate prescribing is a term we don't recognise, I guess, because it's not within our regulatory remit. But as a law enforcement person, I would prefer the person accessed a medicine, the correct medicine, the genuine medicine, than had recourse to the black market where they will be getting anything but that. So at least what you term as inappropriate prescribing would generally result in the genuine product being dispensed. Which is a broadly positive thing.
So I think, would you consider maybe including a contraindication for use on GLP-1s below a minimum BMI? But it seems like what you were saying is that could push more people to go towards the black market rather than...
Well, as I said, I think the issue here is that inappropriate prescribing, although that is its own evil, will result in the person getting a genuine product, and that to me is an important aspect.
Even if it's sort of contraindicated for other health sort of ramifications.
Well, no, I say it's not good, but it's not the.
Would it be right to say a lesser of two evils? Is that fair?
I don't like to use that expression twice in one session, but to some extent, yes. Yeah. I mean, it is something that we thought about quite a bit within my unit about how the difference between the two, and accessing through the black market is by far the bigger evil.
And so, what can take place in this space then to stop people from either getting medications that have potential adverse effects on them because it's contraindicated for other conditions they have, or that are inappropriate, or B, accessing drugs that are completely illegal and could do goodness knows what?
Well, I can only answer the second part of that because, as I say, the MHRA doesn't regulate prescribing practice. That is, the law permits this, and therefore it's not within our remit. But in terms of the illicit trade, we are making inroads into the illicit trade.
I'm going to come to that in quite some depth. Yeah.
Okay.
Yeah. I'll pass back to you then, Jo.
Thank you very much. Josh Fenton-Glynn.
So I'm going to talk a little bit about the kind of online advertising world. So obviously direct-to-consumer drug adverts are banned, but social media is becoming a bit of a wild west, isn't it? Andy, do you think you've got the laws and resources you need to tackle kind of the pharmacies and pharmaceuticals being sold on social media?
You're referencing specifically advertising of prescription
Yeah.
So obviously advertising prescription medicines is unlawful, illegal, and we publish guidance to help people sort of steer their way through what's lawful and what isn't. And we take each case on its merits, and social media isn't excluded by class from this. So social media adverts can indeed fall foul of the legislation in this area. So we recently published guidance to help explain that sort of often subtle, nuanced difference between discourse, which I'm sure we'd all be happy to accept, and illegal advertising. And it is a very fine line sometimes. This isn't about resources, it's about, I guess, that subtlety between the two.
Okay, so I recently read Bad Influence by Deborah Cohen, where she looks at how influencers leverage their kind of parasocial relationships with their followers for GLP weight loss drugs. And in it, she mentions that the advertising agency Ogilvy suggests that 37% of TikTok users bought medicines after seeing them on that platform. 71% of those were unplanned purchases on a whim. So given the kind of potential risks around that, do you think that we need more, and are we able to keep pace with the advance of the technology in terms of our regulation?
So we work with the social media companies, particularly around the illegal trade, which I'm not referencing, but we work with them to get offending posts and advertisements and accounts removed, and quite successfully in that process. In terms of that fine line...
Okay, so you get the posts removed, and
the accounts.
That's great.
Yeah.
The posts are usually advertising a specific pharmacy. What do you do to those pharmacies?
In relation to the pharmacy, so are we talking about illegal or legal sellers?
I mean, one assumes they're legal sellers, but they're engaged in what seems to be unethical activity.
So we will treat each case on its merits, as I said, because of that subtle difference there can be between the two. We'll assess them, and we'll take action to bring those into compliance. And we work with our colleagues in the Advertising Standards Agency to raise awareness of what is permissible and what isn't permissible, and when necessary we will take enforcement action. That's a last resort. Our goal here is to ensure compliance rather than to prosecute, but if something falls foul of the legislation, we'll prosecute.
So I went down a bit of a rabbit hole, which my committee colleagues are used to, So I went through Ogilvy's website, and I'm just using them as an example. It says, TikTok is winning the battle for attention, which is the ultimate precursor to persuasion. This high attention span combined with a personalised algorithm makes TikTok a convenient space to investigate healthcare topics on a peer-to-peer discussion basis. Social media platforms are exploiting people's insecurities, and does it worry you that advertising agencies are choosing to specifically advertise, to sell products of advertising in those spaces?
I'm not sure I could really offer a professional view on that. Social media is a challenge. It perhaps hasn't been designed to be regulated in quite the same way as bricks and mortar. I'm not sure I can really help you much on that, but it's something that we are aware of, and we work with the social media companies, and we recently published guidance too.
I guess my issue though is that a pharmacy is buying the service of an advertising agency that is buying the service of an influencer that is then putting out posts which are at least unethical, in many cases go against your guidance. The book that I referenced talks about how discount codes are offered, how people offer how people are offered financial inducements to advertise it. So what are you doing to the pharmaceutical companies who are offering discount codes to people who then use them in an unethical way?
Well, I mean, again, I might have to come back to you on that. That's outside of my area of expertise, I have to say, but I can certainly report back to the committee if that would be helpful on the detail of that. But we're looking at where these things breach the law. We will take action to enforce the human medicines regulations. That is our statutory responsibility. So we will consider each case on its merits and take action where that's appropriate.
Okay, but so have you taken any cases against a pharmaceutical company that you think is...
I'm afraid I don't have that detail, but I can come back to the committee if that would be helpful.
So pharmaceutical companies have a legal obligation not to sell their drugs. Also, do you think that the pharmaceutical companies, so we're talking Lilly and so forth, who the big producers, do you think that they should have an obligation not to sell their drugs through pharmacies that clearly seem to break the ASA rules and your rules about direct-to-consumer advertising?
I think the pharmaceutical companies should comply with the legislation as it's currently drawn up, and where they do, that's not a concern for me.
Do you think we need more legislation?
That's not really a decision for me to take. We enforce the legislation as it currently stands.
Okay, I mean, but you talked about it being a developing area. Do you think that the legislation is adequate for this developing area?
Again, we can only enforce the legislation as it currently applies, so that's really not a question for the regulator.
Okay.
Okay, thank you very much. So Anna, I'm going to continue with you and talk to specifically the black market bit, which is, by the sounds of it, I mean, I would have thought the two are linked, because the black market is relying extremely heavily on TikTok and social media companies to get their black market wares to... So I'm a bit surprised that you weren't able to give more concrete answers. Can you just explain to me who in your organisation is meant to be, who should we be writing to, who does have that?
I'm not sure I fully understand the question, Chair. So
well, okay, let's start again. You were saying you work with social media companies to clamp down on this stuff. What does that mean concretely?
With the illegal trade,
yes.
So my reference was with illegal trade. So we have routes into the social media companies to ask them to remove offending posts, and where we can demonstrate that an account was being used more than, we can reach a higher standard of evidence, they will actually remove the whole account, which then removes many, many thousands of offending posts. I accept that's a bit like whack-a-mole, and I fully acknowledge that, but that's the nature of the territory in which we're operating. Social media companies, the sheer volume and the speed with which these things can be posted. That's not excusing the social media companies. That's just the reality of the world.
And in reality, I mean, is it you reporting these accounts? How are you so talk me through the chain of how this happens. How much of it is the social media companies going, actually, we are concerned with anyone trying to sell any medicine on our platforms, and we're actively trying to enforce rules. That's the gold standard, versus you getting a tip-off from someone that you need to be looking at this account. I noted in a letter you wrote to me, the organisation wrote to me not that long ago, you disrupted 190,000 website and social media links last year. But how much of that was proactive, you going out and seeking this out, and how much of that was being told to you, and how much of that also is representative of how big this problem is? Give me a sense of the scale here.
Okay, so I don't have the exact numbers, I'm afraid, but if it would help, I can get those for you.
Always.
Yes, of course. So we proactively patrol, for want of a better word, the internet ourselves. So within my units, we have officers that do that, and we're looking for trying to find those things.
And how many officers are in that bit of the unit?
So I have a total of 55 at present in total. So
that's trolling the internet, looking for stuff.
That's doing the whole range of duties that we have.
Oh, that's your entire unit.
So I would say half a dozen staff dedicated to that area of work. So we will find our own. We will get public reporting, and we rely very heavily on public reporting and encourage the public to do so. And we will report those to social media companies to get them to remove them. I sense your question is the extent to which social media companies are proactively doing this of their own volition. I guess that you'd need to ask social media companies, but I do feel there's more that could be done.
We're not about to ask the burglars how many, that just doesn't make any sense to me.
No, the point I was saying...
You're the regulator, you should have a sense of how big this problem is.
The issue with social media particularly, yes, I take your point, but there is that area between legitimate discourse and selling medicine illegally that I come back to, that is sometimes a very fine line. But where we find these things, we will take action. And I think there's more social media companies could do proactively to remove them at source.
Is the line too fine? Is that the problem here? That you worry about whether or not it's, you know, like, should we be giving you a firmer line?
I think there's some of that. I think ultimately it's the social media company to determine whether to take these things down or not, whether they believe that they're in breach of the law. We can ask them to. We can't compel them to. And I think that's a big
You
difference.
currently do not have the power. If you are seeing, and you know, I've got examples of social influencers based out of Thailand who are selling to people here in the UK. Turns out the beneficial owner of this company is a UK citizen. They've got several accounts across several platforms. Some were shut down. They just immediately opened up, basically with a very similar output. But if you tell the social media companies you must shut these down, they actually can just say, actually, no. Is that the case of where we are now?
That is where we are now. We can investigate, so we can investigate any UK connection to this, and we can prosecute the individuals involved in it. But ultimately, the social media companies, invariably are not within our control.
Can you act on...
Hold on. So Tony Saggers said, who's the former head of Drugs Threat and Intelligence at the NCA, described these drugs as the supply is as bad as the illicit drugs like cocaine and heroin. I mean, would you agree with his assessment of how dangerous some of these drugs are?
We're talking about GLP-1s.
GLP-1s, yeah.
Okay. So that's not my experience. I know Tony, and I can say, I understand the point he's making, that these are, the profits, I think, are equivalent, if not in excess of, in some situations, with medicines generally. With GLP-1s, the illegal black market products that we've seized so far, and we've seized around 81,000 doses over the last 3 years that we've been working on this, because that's the duration of the crime in this case. 81,000 sounds like a huge number, but it's not in comparison to the total number that we seized, which was 20 million last year. Doesn't mean to say it's not important, doesn't mean to say it's not a priority for us.
Well, just in this country alone, I mean, as we've heard, we've got millions of people who are eligible on the NICE guidance, let alone those who are after it for a bikini body who shouldn't be taking it but are turning to the black market to do it. Have you got a sense of the size of the problem? How you alluded to it here. Did I just hear you correctly? The financial size of this black market is bigger than cocaine and heroin? Is that what you just said?
Apologies. The margin, the profit margin.
The profit margin
can
is
be
larger.
Greater. Not the overall.
Not the
volume.
overall size of the market. How big is this black market?
In medicines generally, I mean, if to the extent to which seizures are a proxy for the size, which is, I guess, as best as we're going to get, because it's a hidden crime, like most criminality is, so it's hard to get accurate prevalence numbers. But if the scale of our seizures is a proxy for the scale of the market, then the medicines illicit market is substantial.
How big?
We seized 20 million doses, and even my most optimistic, I would say that's certainly no more than 5 or 10% of the total. So that gives you an indication. With GLP-1s, it's much, much, much smaller, as I said. So 81,000 in total, and using the same sort of calculations, we're looking at relatively small. But it is a priority. But I guess the point I was making at the beginning, Chair, if I may, was that what we find with the products we have seized, GLP-1s that are illegally traded, it is the genuine product 99 times out of 100. That doesn't make it safe. It hasn't been produced in accordance with genuine manufacturing processes. It's not been, the sterility is questionable, the dosage is questionable, all those things that we're well aware of. So it's absolutely not safe, but it is the genuine product. And the side effects that we're seeing from the fake products, or the non-genuine products, are broadly comparable with the side effects of the genuine product. So from a purely public safety perspective, this is not keeping me awake at night in quite the same way as other aspects of medicines trafficking is.
So I've met with a family who whose mother, so it was Abby and Fionn McGonigal, and their mother Karen, and I've written to the MHRA about their case because they're bravely campaigning through their grief. She turned to the black market. It was a local Botox provider, I believe, who gave her this jab illegally. And I understand there is an ongoing investigation with Greater Manchester Police. So are you saying to me that their case is rare? Because their concern is that their mother, Karen, is the tip of the iceberg. And the number of people out there who are concerned that it could well be, there are still tests ongoing to check whether it was the actual drug itself or whether it was sepsis or whatever. But would you not accept that us not getting a grip of this illegal market is in part a contributing factor to Karen's death?
I have a great respect for the McGonigal sisters. I've met them and was very impressed by their work, and it's extremely beneficial to the overall threat that they're out there talking about this, because I spoke at a Lilly conference only last week, week before last event rather here, and the message I gave was that this is all about the three most important things are reducing demand, and reducing demand. Mm-hmm. And interventions like the McGonigal sisters talking about this publicly, about the sad demise of their mother, is so important in getting the message out, because I honestly believe that a lot of the people that are buying these products from the black market don't know they're buying from the black market. Yeah. There's been a blurring of the edges between a medicine and a cosmetic over the last 18 months, 2 years, that is extraordinarily unhelpful. So part of my role and the role of my agency is to re-establish that boundary. And but your point is right. One death associated with these products is one too many. But the question you asked was around what we're finding within them, and what we find within them is it's a genuine product. Mm-hmm. So there can be other factors that play into the bad outcomes that we're hearing.
And so you've identified, I'll look at the transcript to play it back, maybe you remember it better than I, what you just said. So it's the job of your department to unblur the lines, by which I take it should never, if you could turn back the clock 2 years, what would you have put in place to ensure that those lines were less blurred, A, and B, what do you need to do now to both unpick this and to reassure the public that you're on top of it? I have to be clear with you. I don't feel that the MHRA is on top of it. I think that so reassure me and the public that you've got this.
Okay, I genuinely believe we do have it, and I know I would say that, wouldn't I? But this began for us in March 2023 when NICE approved semaglutide for weight loss. And from that moment on, this has been a priority for my organisation. From the day I heard it on the Radio 4 News, the morning of the NICE announcement, we've been prioritising this as a unit. And the first wave of criminality we saw coming out of this, which we predicted, we were ahead of the game at that point, Chair. We saw it coming. And we saw fake Ozempic products. These were brand-infringing Ozempic products that contained insulin that could kill people. Mm-hmm. There was no greater priority for us at that point. And we seized around 900 individual pens that had been counterfeited, that any one of which could have killed somebody, quite frankly. And I think we did the legs of that particular model. So we were ahead of it. We were equal, if not ahead of the criminals on that occasion. Criminals diversify. That's what they do. The money was still there for them. So they changed to producing these awful little generic syringes filled with noxious liquids and vials full of powders that they were selling through social media again, through websites and through backstreet to beauticians and those kind of places. And that's where the edges start to become blurred. When these products were not labelled in any sense at all. You eventually went in, you paid your money into your beauty salon, and you came out with a syringe, or you came out with a sore arm after having had a syringe. And that's where these things cease to become medicines in people's minds, I think, or many people's minds. And whilst they were expensive to buy for the customers, the efficacy, I suppose, of GLP-1s was the thing that was driving that demand at the time. So we cracked down on that, and we seized many of those, and we were sending officers all over the country to deal with individual outbreaks of this particular model. And then again,
how were you being made aware? Just paint a picture there.
Through all the things I mentioned earlier. So we have undercover officers working online. We do all the things you'd expect a law enforcement unit to do, unique globally within a regulator for medicines, I hasten to add. So we have dedicated staff that are out there looking for these people, looking for this stuff. And I obviously can't tell you too much about how we do and what we do, but the point is we are doing the things you'd expect us to do. And I genuinely believe we're leading the way globally in the UK in tackling this criminality, to the extent that within the last 12 months we identified, built up the intelligence around and raided the world's first manufacturing facility for the third wave of criminality, which were these highly sophisticated products that you may have seen through our raids that had their own branding. Yeah. They weren't pretending to be a brand name, they created their own branding, which is even worse, and blurring that line even more. What could we do more of? I think the solution to this, having been in law enforcement for a very long time, we cannot arrest our way out of this. It is about educating the public, and that's been a theme throughout the whole of this morning's session, I think. It's about raising the awareness of the public, and we do that, and I spend more time on TV than I spend in my office at the moment doing just that, because I think that's the key to cracking this. But I can reassure you, and I can reassure the public, that we're on this. We have the capability we need, we have the capacity we need to address this problem.
That was my question. So you don't need one more extra officer.
I didn't say that. Of course, there's always more that can be done, and we regularly monitor the size and shape of the resource we put into my unit, and that process is ongoing as we speak. So I will always welcome more resources. So please don't get me wrong on that one. But at the moment, we are fit for the purpose that we're here to perform.
Is one of the other issues here that, I wrote down Swiss cheese regulatory model. Neha, I think when you were speaking, and you've got the CQC, you've got yourselves, we've got the MHRA, we talked about a regulation gap. Can you help me out here? We want to recommend to government how we can get on top of this. And it's not just the regular black market, it's also the illegal prescribing. They go together, they go hand in hand. And it might well be that you've got someone it's not a black market drug, but they are prescribing it inappropriately, and that itself is going to cause harm, isn't it? If you're going to be prescribing it to someone with anorexia. I'm not sure the public really care which regulator does what, but they want to be reassured that it's safe. Add on top of that the fact that cosmetics aren't regulated in quite the same way, and you've got a bit of a perfect storm. What more can we do, Neha? What do we need to get government to do differently?
Yeah, as in over the last year, well, I'd say more, maybe even year and a half or so, we've been working much more closely with other regulators as well. I mentioned CQC. We engaged with DICE, which you'd heard in the first session as well, including with MHRA and ASA as well, relating to the black market and to social media influencers. We have done joint enforcement notices as well, and a joint webinar that we did last year. So we are trying to collaborate a bit better and work together so that we fill those gaps and show like kind of a one approach to the public, because like you said, that's what they care about, and we are here to represent patient safety and promote patient safety. So coming together and sharing those sorts of learnings or our intelligence only supports that, and any government to share that messaging to help with public education. What is it you concretely want to see? You want a government paid for backed public education campaign about the dangers of badly prescribed drug. What is it exactly you want government to do? Because if you can't tell us, we can't recommend it. For government, for me, like one of the first things I would say is rewinding back from that is access to records. Like I think that was highlighted in the first session. Now, I'm not trying to say that if a private pharmacy doesn't, or a private provider doesn't have access to records, that they're not doing that safely, but supporting that access only helps clinical decision making and safe prescribing choices. So that would help with the inappropriate prescribing aspect of it. In terms of like the education angle, only more education is only going to be good for the public, because like seeing things on social media, on TikTok or whatever other platforms people are using to say that this is how you should access your medicines safely is only going to help that, for people to understand the risks of, I know Andy mentioned that, in terms of weight management medicines, like most of them are still GLP-1s, but there are a small fragment where they're not, and we don't know what that is, what the risk is of taking that medicine. And to make it a real life scenario is only going to help those sorts of situations and minimize people accessing those black market routes. And I guess the other thing is in terms of like thinking about access to medicines in terms of affordability as well. We know that the medicines are available on the NHS, but for BMI over 35 with one comorbidity, it makes it less accessible for people that are floating around over 30 but don't have a comorbidity and can't afford the medicine. Is that pushing people down the black market road as well? Supporting access might help reduce kind of going down the wrong angles to get it.
There's a safety aspect to that. Andy, you spoke about education. What if you had the money to run a government-backed education campaign in this area, what would it say? What would the tagline be?
That's a big ask. I think what we need to do is speak to people where they are. I think sometimes regulators can come across a little bit condescending, and we don't necessarily, people perhaps of my age, don't necessarily know how to speak to some of the people who are accessing these things who might be a different demographic. I think we need to, it's more about how we say it and where we say it, because if there's a social media narrative that's overwhelmingly positive and promoting GLP-1s, then we need to get there and have a similar narrative, change that narrative about correct access to it. And sometimes when we make it overcomplicated, it is fairly binary. Certainly for the illegal trade, it is fairly binary. It's about where you've got it from. If you've got it on prescription from a registered pharmacist, you're golden. If you haven't, you're not. And it's that simple. Sometimes we complicate the messaging. So a simple message delivered to people where they're at, rather than necessarily where we'd want them to be. We've been saying this for many, many years. Don't buy medicines from illegally trading websites. Not sure the extent to which that's really resonating with people around GLP-1. So I think that to me, and we've worked with social media influencers. I've personally worked with social media influencers to try and get the message out there, to have that counter narrative. And I think that's the future, I think.
Thank you very much. We've run over. Thank everyone for their patience. Order.